Welcome back to the Health Longevity Secrets Show, and I'm your host, Dr. Robert Lufkin. The idea that Alzheimer's disease can be prevented and even reversed is transforming the medical world. Today, we get to speak with one of the key people responsible for this revolution. An internationally recognized expert in the mechanisms of neurodegenerative diseases, Dr. Dale Bredesen's research explores previously uncharted territory in explaining the physical mechanism behind the erosion of memory seen in Alzheimer's disease, and has opened the door to new approaches in treatment. This work has led to the identification of several new therapeutic processes that are showing remarkable early results. Dr. Bredesen is a prodigious innovator in medicine with over 30 patents to his name. Notably, he put much of his findings and research into the 2017 New York Times bestseller book, The End of Alzheimer's. His most recent book, The First Survivors of Alzheimer's, also presents the stories of 7 individuals who reversed their cognitive decline using his Recode protocol. Dr. Bredesen graduated from CalTech and earned his MD from Duke University and served as chief resident in neurology at the University of California, San Francisco, before joining Nobel laureate Stanley Prusiner's laboratory at UCSF as an NIH Postdoctoral Fellow. He has held faculty positions at UCSF, UCLA, and the University of California, San Diego. Dr. Bredesen also directed the program on aging at the Burnham Institute before joining the Buck Institute in 1998 as founding president and CEO. And now, please enjoy this interview with Dale Bredesen, MD. Hey, Dale, welcome to the show.
Thanks very much, Rob. Great to be here.
Yeah, well, full disclosure, I think you and I overlapped a little bit when we were both professors at UCLA. I don't think we met then. We've met after that, and been working together on a few projects since then. I'm so excited to talk about the work you're doing about changing the world of Alzheimer's disease. And also, I want to mention your new book, The First Survivors of Alzheimer's. I highly recommend it to everyone, as well as your other 2 books. They're probably my go-to books on Alzheimer's disease. I recommend them for everyone who wants to get up to speed with the latest, best thinking on it.
Thank you.
But before we dive into those, perhaps we could set the stage and maybe you could set the stage and tell us a little bit about maybe when you knew that you wanted to work in this area.
Yeah, it's a great point. So I got interested in the brain. I was an undergrad at CalTech years ago, and I got interested in how the brain functions and how it's similar to a computer. And then from there, I got interested in, what brain diseases, how does this work? And so I became a neurologist. And of course, as you know, the area of neurodegeneration is the area of greatest biomedical therapeutic failure. So whether you've got ALS or frontotemporal dementia or Alzheimer's disease or Lewy body or PSP, or so you just go right down the list, this has been an area where medicine has had nothing to offer. And unfortunately, these are horrible diseases, as we all know. And they are, they've been death sentences for so many people, and they're very common. So Alzheimer's, as Professor Christine Yaffe from UC San Francisco has pointed out, now the 3rd leading cause of death in the United States. It's actually the 2nd leading cause of death in the UK. So these are very common. And just for comparison, for perspective, we've now had over 700,000 people in the United States die from COVID-19, the pandemic. Nearly 100 times as many will die of the currently living Americans will die from Alzheimer's. So this is a very common problem, and there just hasn't been anything. So I got interested in basic research. Could we understand the fundamental nature of the neurodegenerative process well enough so that we could begin to fashion the first effective treatment? So we've been interested, and so we spent years, we published over 220 papers in peer-reviewed journals on what actually drives the degenerative process. And so right back in 2010, 2011, we realized, okay, This is driving us to a completely different model of what Alzheimer's is. So as you know, the standard idea was Alzheimer's is because somehow you collect amyloid in your brain, and that's bad for your brain, and it's, quote, misfolded proteins. And what we found was completely different. The research shows that this is actually a response to various insults. So you have this amazing molecular switch in your brain, which is amyloid precursor protein. It's the thing that gives rise to the little fragment of amyloid. But literally, this thing will switch back and forth when things are good. And there's a direct analogy, of course, to what happened with COVID-19, where we were all told there's an insult, SARS-CoV-2. We're going to socially distance. We're going to shelter in place. We're going to not go to work as often, all these things. And what happened? The country went into a recession. So your brain does very much the same thing. When times are good and you've got enough nutrition and you've got enough hormonal support and nerve growth factor and BDNF and all this, all the good things going on, your brain makes a decision. It's going to make and keep synapses, and you can make new memories and learn new things and all that. When things are bad, you have ongoing systemic inflammation, infections in the brain, exposure to toxins, poor nutrition, menopause with very low estradiol, any of those things. You now have a mismatch between the supply and the demand. And so your brain switches to a mode of protection. And when you make the amyloid is a beautiful antimicrobial peptide. And that's been very well shown by Professors Robert Moyer and Rudy Tanzi from Harvard, who showed a number of years ago that this is an antimicrobial peptide. So this thing that we vilified as the cause of Alzheimer's is really a response to these various insults. And that tells you to prevent it and treat it, you have to do something completely different. You have to determine for each person, why is the brain defending itself? What are the insults that it is responding to? Then you can go after those, and we have better results than have ever been published previously. We've done a number of papers. This is what I also put in the book, and we've just finished the first clinical trial in which, instead of predetermining a treatment that is one size fits all, which has never worked, we're looking for each person at all of the different parameters. Do they have unrecognized pathogens? Do they have unrecognized toxins? Do they have insulin resistance? Do they have leaky gut? And just go down there, dozens and dozens of things. But you see then that what we call Alzheimer's is really the brain defending itself.
So Alzheimer's disease is really much more complex than we thought it was. And it's this reaction to things. And I wonder, what is it about Alzheimer's disease that's, arguably resisted the efforts of some of the greatest minds in science and medical care, and essentially unlimited financial resources over the last 20 years to come up with any sort of effective drug for it?
It's a great point. And the answer is because we all understand the concept of systems medicine and systems biology, but virtually nobody practices it. So everybody is making the assumption that there's one thing that's causing the problem, and we're going to go after that, whether it's amyloid, tau, prions, misfolded proteins, reactive oxygen species, you name it. People have thought about, is it herpes? Is it type 3 diabetes? I mean, there are all sorts of ideas, but everybody wants this to be one thing. And of course, all the pharmaceutical development has been around a single small molecule. So imagine that you have all sorts of issues. The country's in a recession, and there are all sorts of things that are driving that. And that everyone was saying, well, what's the one person we're going to hire that's going to make it so that the recession just disappears? It's just not that simple. So I think we're all understanding more and more that the idea of treating something with penicillin because there's a simple pneumococcus, that's a 20th century approach. This is now the 21st century, and we're dying of complex chronic illnesses. This type 2 diabetes, cancer, cardiovascular disease, Alzheimer's, all the neurodegenerative diseases. So we have to change. We've switched from checkers to chess, and we have to change the way we evaluate and treat patients with cognitive decline.
It's almost as if our failure with Alzheimer's to find a single drug is representative of a bigger failure in treating essentially all chronic diseases that we're failing at. But the other chronic diseases like stroke, like diabetes, like hypertension, like a heart attack, all have some sort of identifiable mechanical or biological symptom you could treat. Like, a heart attack, you put in a stent or you replace the plumbing, but it really doesn't fix the root cause, which is metabolic disease. And with Alzheimer's, there's no symptom really. Cognition is really hard we still don't even know how the brain works. And so it's especially hard to do anything about that. But
and if I could just comment on that, this is a really important point, because what happens is we used to think of this as a disease of old age. What's now become clear is that the pathophysiological changes start about 20 years before a diagnosis of Alzheimer's. And as you well know, that's been picked up both by longitudinal PET scans, but also by cerebrospinal fluid. So you can see the beginnings of changes. So really, this is a disease of your 40s, 50s, and 60s. It's diagnosed in your 60s, 70s, or 80s, and can be even into your 30s that you can pick up these abnormalities. So what you really want to do is look for those things as early as possible. And one of the big problems is everyone's trying to treat this in its last stages. And think about it. When someone says you have mild cognitive impairment, it includes the term mild. This is like telling someone you have mildly metastatic cancer. It is a late stage. So in Alzheimer's, as you know, there is a stage in which it is asymptomatic. Then there's subjective cognitive impairment, which lasts about 10 years from epidemiological studies. So the window is huge for us to treat. And virtually everyone with SCI can get better if you do the right things. The third of 4 stages is MCI, mild cognitive impairment. And it's that final stage that we call Alzheimer's disease. So that's been the problem. As you know, you have to begin to lose your activities of daily living. So this is a late stage of decline. If people would simply switch to getting this evaluated early, and think about all the great improvements that we had with colonoscopies and pap smears and mammography, we need to do the same thing for cognitive decline.
Yeah, and I want to talk about prevention in a second, but before we leave the overall Alzheimer's issue, I have a confession to make. My mom was diagnosed with Alzheimer's a few years ago, and we got the best medical care in the world at the time, which was to basically put her in a room and wait for her to die, which she did a few years later in 2017, which is incidentally the year that your New York Times bestselling book and your work became widely known. The problem is that I wonder about is currently the state of many, if not most patients with Alzheimer's disease still receive the treatment that my mother got. And why you've published clinical trials, randomized clinical trials showing the effectiveness of this work. And, other people are, there's a groundswell of evidence, scientific evidence of how effective this is. Right. I wonder, why is there so much resistance from our colleagues? Is this been politicized somehow? Or why aren't people shouting this from the treetops and giving everybody ketogenic diets in nursing homes? And, these are simple things.
Right. It's a good point. And there are a couple pieces to the answer. And it really shows, how medicine changes. It takes time. As you know, the phenomenon of scurvy, there were people each century, 16th century, 17th century, 18th century, 19th century, came up with something to do about scurvy. And each time the experts said, no, that's not it. And so thousands more died of scurvy until 100 years later, they did the same thing. It's really a sad history, unfortunately. But one of the issues is that there's a fundamental change in the way we think about medicine. The 20th century medicine that you and I went to medical school for was about where to determine what it is. Is it a brain tumor? Is it Parkinson's? What is it? And then we write a prescription or we send people to surgery. That's medicine. 21st century medicine is about why is it? It's a systems medicine approach where we're looking at all the different things. And it's interesting, you already see this, Google knows where you shop. They know what you do, as they say, they probably know a lot more about you than you want them to, because they have sophisticated computer-based algorithms that follow you around. Why aren't we doing the same sort of thing for looking at all these physiological parameters? That's where medicine is headed. It'll be much better when we can say, here are all the things that are causing your cognitive decline, your hypertension, your renal failure, what have you. We will do much better. So we're asking people to abandon the way that they were trained in medicine. That's very hard to do. But the second thing is actually quite interesting. If you look back at the opioid epidemic and the opioid scandal that really came to a head, and there are now these multiple documentaries, you can almost place it on top of what's currently going on with Alzheimer's. What happened? There was a company making billions of dollars that used that to create a coercive infrastructure to tell doctors, this is what you're supposed to do. And they then did things which unfortunately resulted in unnecessary deaths. We're in the same situation now. There is a coercive infrastructure, as a very nice op-ed recently from one of the experts who said that everyone who wrote a very positive review of aducanumab, the drug that was just approved, was paid to do so. So everybody was a paid consultant. The Alzheimer's Association was paid over $1 million by Biogen to say that their drug was a good drug. And this is really sad because, as you know, it doesn't make people better. It doesn't halt the decline. What it did was only in one trial at one dose, it slowed the decline by 22%. So we need to do better than that. And unfortunately, we've got unfortunately, it's been more about incomes than outcomes. We need to focus more on the outcomes and less on the incomes.
So yeah, very, very good point. I mean, what you're saying, I guess, is part of it. Language matters, and how what we call the disease matters. Like we have a symptom, it's not really a disease, but fever. And
Yes.
fever can be caused by a pneumonia or an infection, or many different things can cause fever. And if we look for a treatment for fever, giving an aspirin will lower the fever, but it doesn't take care of the root cause. I wonder, and with what you're saying with Alzheimer's disease, do you think there would be value in renaming Alzheimer's disease if we had like mold-related Alzheimer's disease or inflammation-related Alzheimer's disease, or are they too interrelated for that to really be valuable?
This is a great point. And as you know, Alzheimer's was defined pathologically by Dr. Alzheimer in 1906. So this has always been a pathologically defined disease. And what we're now understanding is that there are many things that contribute to that pathology. And there are four basic groups. But what we did was we subtyped this, and we can find that there are 6 different subtypes. So there's a more inflammatory form of Alzheimer's. There's a more atrophic form. You can get to the same place by doing different things, by withdrawing support. Since this is really about supply and demand, you can either make the demand higher, which is what happens with inflammation and toxicity, or you can decrease the supply, which is what happens with energetic loss and trophic loss. So you do see people, as I said, inflammatory Alzheimer's, atrophic, and then glycotoxic. So many people have insulin resistance as part of this. It's one of the most common contributors to cognitive decline, as you know. And then there is toxic, and that can be 3 different types of toxins, inorganics, and of course, anyone who's been in the California fires has an increased risk now because of this air pollution. And of course, anyone who's a lot of exposure to air pollution, some very nice work on this at UCLA and USC on looking at air pollution and its increased risk for cognitive decline. And then the organics as well, formaldehyde and benzene and things like that. By the way, the people who were in the World Trade Center who were first responders, over 15% of them now have cognitive decline. And so definitely this being exposed to these very poor air quality is a huge issue. And then the third group is toxins. And these are biotoxins, things like mycotoxins, as you indicated. I was never trained as a neurologist that toxins produced had anything to do with cognitive decline. But it's become very, very clear, and there are many reports now, especially people who are exposed to trichothecenes from Stachybotrys, often will have some degree of cognitive decline. So that's what we call type 3 toxic. Then type 4 is vascular, and type 5 is traumatic. And so all of those things can lead to this pathology that we recognize as Alzheimer's disease.
And one of the hallmarks of your approach is being very open-minded to different strategies to do whatever it takes to address these multiple factors in there. I'm wondering what's your take on the rapamycin has been used for longevity now as an off-label FDA use for suppressing mTOR, and it's having a lot of very interesting effects in very different areas. And there's the University of Texas study is beginning to look at rapamycin for Alzheimer's disease. What are your thoughts on that?
Yeah, no, it's very interesting to me. And again, all of these kind of, just as we talked about monoetiological ideas about Alzheimer's, these monotherapeutics tend to unfortunately ignore many of the critical features that are actually driving the illness. I think the place for these drugs, and I would include rapamycin, is as part of an overall protocol as opposed to just monotherapies. Rapamycin is not going to do much for people who have extreme exposure to mycotoxins. It's not going to do a lot for people who have ongoing pathogens that you have to deal with, unfortunately. So it's interesting, if you look at the longevity drugs like metformin and rapamycin, you really have three different major pathways for longevity, and they all have something to do with energetics and food. And so, you want to get AMP kinase activated, for example. You want to inhibit, mTOR, that sort of thing. These are all about food, and really come back to the fact that we're all eating inappropriately and with high simple carb diets, unfortunately. And that's what's driving. So the idea, you can try to make your longevity greater with metformin, or you can just quit eating all the simple carbs and you don't have to do the metformin. So of course, we always want some way to get around doing the wrong thing. But in fact, the good news is, I think we're all beginning to agree on these critical pathways for aging and for cognitive decline. And you may have seen a fantastic paper by Dr. Kara Fitzgerald, just came out a couple of months ago, where she used the methylome, which is a very good look at aging, very good association with biological aging. And she was able, just by essentially doing the right things for people, she was able to get them to reverse their aging by about 3.2 years compared to the control group. So we can show now a backwards aging. Now, no one's seen Benjamin Button yet. You're not going to go back to zero, but you definitely can age in reverse for at least some period of time and do better than you would have otherwise, which I think is really exciting.
Yeah, that's fantastic work. Yeah, Kara was on the show, and we also Lucia Aronica up at UCSF is another investigator that's using DNA methylation epigenetic clocks with ketogenic diets to wind it back. It's so fascinating, and it's all these things are we're seeing these relationships at a fundamental level, even with Alzheimer's disease and all. It's so fascinating. There's so many things going forward. Speaking of people on the show, we had one other person, Liz Parrish, who is the CEO of BioViva Sciences, which is a gene therapy company, and they're investigating a number of gene therapy projects in humans. But one thing they used was a gene called Klotho, looking for cognitive impairment, and they're just publishing a paper that's showing some improvement with Klotho there. And obviously, this isn't, like you say, there are better ways to improve your cognitive impairment than going all the way to gene therapy. But yeah, any thoughts on that?
Yeah, no, and that's right. Klotho was picked up as an association with better cognition, now about 10 years ago. And I think it's a very interesting phenomenon. And again, we're beginning to build an overall look at what is this network. Again, what we see as Alzheimer's is really a network disorder. And so, yes, Klotho is part of that, and methylation part of that. SAPP alpha, all these different pieces come together, and mTOR, all these things. You look at things like resveratrol. I was skeptical at first when resveratrol first came out, but what's very interesting about it, it enhances the cleavage of APP at the site that's going for the building side. So it's very interesting. You can look now at what are the things that drive amyloid precursor protein to go to push your brain toward making and keeping synapses, and what are the things that push it toward pulling back. So you're literally switching your brain to a protective downsizing mode. And it's intriguing that these things are linked, that the protection and the downsizing are unfortunately linked. So when we're protecting our brains, we're saying, well, we can't support the brain that we have, but we can support a smaller brain. So we're going to down a little. And unfortunately, when you go to a standard center for memory and aging, they don't get rid of the things that are causing the downsizing. So you just, as you saw with your mother, unfortunately, you just keep going. So if we would all simply find out what our risks are for these different things, we really could dramatically reduce the global burden of aging. And that's the goal.
Yeah. One thing I loved in your book was a chapter that I hadn't heard before was you talked about normal cognition versus optimal cognition. And these would be people who may be just on a prevention protocol, and we want to talk about Precode and Recode a little bit later. But before we do that, the normal cognition versus optimal cognition, that is taking regular people and making their thinking even better, sort of clearing the subliminal fog they may not even be aware of. That's such a fascinating idea. And you mentioned nootropics for those
yes,
as a possible path.
As part of it, yeah. And just to explain a little about that. So, you brought up a really important point. This is the issue of our age. Since the pandemic, what is everyone complaining about? Brain fog. And it's, so everybody knows that if they stay up all night, they're not quite as sharp at work the next day. And so, in fact, this is what's happening. Most of us are not operating at our best because we may not be getting enough sleep. We may not recognize that our oxygenation is not quite as good as it should be. We may have a degree of insulin resistance. We're dealing with that. We're kind of keeping that at bay, but in so doing, we're not at our sharpest. And one of the things, as you know, when people start getting on a mildly ketogenic diet and start kind of fixing these various things, we call them the 36 holes in the roof, so that people will understand that it's more than one thing. They start noticing, wow, I have more energy. They often will lose some weight. In fact, a lot of the people in the trial that we did were able to get off their antihypertensives, their statins, and their anti-diabetes drugs because they're now having a more optimized metabolism. And these all are contributing. We may not get Alzheimer's, but we're certainly not doing the best we could. And so, sharpening people up is a real goal here. And so, yes, nootropics are definitely part of that, but there are all sorts of other things, just looking at the things that are driving this suboptimal decline. And we walk around thinking we're normal, but we're really not at our best.
So in addition to the nootropics, one would think that the same things that would work for reversing Alzheimer's and preventing Alzheimer's would also work for optimizing functions. What else do we add beyond what we would do just for normal prevention if we want to optimize our cognition to this new higher level? It's such a great concept.
Yeah, it's a great point. So you have to be careful because, as an example, everyone knows, you can be sharper, as has been shown in papers for years and years and years. You can be sharper for a few minutes with amphetamines. You can be sharper for a few minutes with cocaine. You go to the college dormitories, what's everyone doing? Adderall, left and right. And so you have to distinguish between short-term smartness versus a long-term. We want to give people long-term, better sharpness. And so, yes, some of the nootropics are quite helpful for this. but also just improving things like BDNF can be helpful for people. Getting them, getting their homocysteine down to optimal, again, not to normal, but to optimal. These often will, as you know, have a slightly excitotoxic effect. Now you have to be careful. Alzheimer's is too much excitotoxicity can drive decline, but modest improvements are what some of these nootropics will actually do. And then, people for thousands of years have used things like Shanpushpi, things that come out of Ayurvedic medicine, and Bacopa and ashwagandha. And so, adjusting these things and basically you can do this by following yourself on things like Brain HQ, looking at your scores and seeing how you do. And of course, there's brain training everywhere now. You can do it through, all sorts of different, all sorts of different, brain training programs. I happen to like Brain HQ simply because, not because I have anything to, I don't work for them, but they have the most publications that support their work. But any of these things, Doximity is another one. A lot of people like one called Elevate. It's fun for people to do. And you can see your scores doing better, not only as you practice, but by doing the right things and by looking at as you said, at the chapter in the recent book where we went through all these different things that you can look at.
Oh, that's great. Yeah, we'll put those in the show notes for everyone. And since we're talking about nootropics and other things, what about psychedelics, the default mode network? It's a whole different area, but MDMA, psilocybin, it looks like they're going to be, they are being fast tracked by the FDA now, and they have real uses in PTSD and depression. Any thoughts here in the work you're doing?
Yeah, it's a great point. And there's a lot of interest, as you said.
Ketamine.
Microdosing. So the standard doses don't seem to be helpful for cognition. At the micro doses, they may be. And it's so far, it's looking more like for people who have the exact overlays that you just mentioned, who have a bit of PTSD as a problem, some depression, things like that. We'll see. I mean, time will tell whether these actually have an effect for people who don't have those other the psychiatric related manifestations in terms of just pure cognition, because they do often inhibit pathways that are involved with cognition. But this may be a kind of a hormetic effect where you're creating a mild stress, and then your brain is, your body is coming back better. And this is one of the things, by the way, you may have seen just some recent interesting work from Israel, which I heard presented actually at Amazon a couple of years ago, where what they were doing is using hyperbaric, but they were doing it in cycles where they would have people improve their oxygenation, which gave them now improved energetics, and people would get some better, but then they would cycle them for about 5 minutes, where they didn't go into hypoxia, but they went into a short-term relative hypoxia, which then causes the production of more trophic factors. So by this cycling, they actually got quite nice results with their patients with cognitive decline.
Yeah, oh, that's spectacular. Well, back to prevention versus treatment, and you have programs. Precode is for prevention, and Recode is for treatment. Given that Alzheimer's disease, like you say, is present 10, 20, even 30 years before mild cognitive impairment, it's almost as if the prevention, we're really just treating subclinical disease. And it doesn't matter, or is it sort of academic? I mean, the treatments are the same, right? So, I mean, more or less.
Yeah, so one is just more extensive. So we created initially Recode for reversal of cognitive decline. And yes, once you're far down the road, there are all sorts of things you have to do. But we realized, okay, one of the people who was doing quite well said, well, look, I'd like to have my whole family be on prevention. And we recommend that anyone who's 45 years of age or older, just as we know, what do we all do when we turn 50? We get a colonoscopy. Well, if you're 45 or older, you should have a cognoscopy. And that's basic 3 things. It's a series of blood tests that will look at these different features. It's a simple online cognitive test. And then if you've got any symptoms or you're scoring poorly on the cognitive test, of course, you want to include an MRI with volumetrics. That's critical as well. So everybody should get a cognoscopy, and especially anyone who has a family history of cognitive decline. And that way, it allows us, just as everyone knows their blood pressure and their cholesterol, but virtually no one knows what their risk is for cognitive decline. Most people don't know their HSCRP, their homocysteine, their C4A, their urinary mycotoxins, these sorts of things that are actually risk factors. Now you're armed with that. And so Recode creates a preventive program. And so the good news is, when you're preventing, you don't have to do as much. It's just like if you start the ship out in the right direction, it's a whole lot easier than once it's steaming down to try to actually turn that ship around. Much harder to do that. And so the good news is, when people get on appropriate prevention, we have not had any cases of those people who now progress to dementia. So we believe that, time will tell, but we believe that that this is something where we can really reduce the global burden of dementia. And by the way, we have people, the very first people on Recode started in 2012, and they're still doing well 9 years later. So that when you are attacking the things that are actually causing the problem, you get a much better outcome. Whereas, as you know, when people have gone on the drugs, they may get a little bump, but they go right back to declining. And in fact, there's a paper showing that in the long run, they do no better than the people that weren't on the drugs.
Now, let me underscore that a little bit too, what you said about Recode for prevention, that at least so far in the patients in your Recode program, none have progressed to Alzheimer's disease. And that may change in the future, but so far that's very dramatic results. And Recode and Recode, is that something they can sign up through Apollo Health, or how do they get engaged with those programs?
Yeah, it's very simple. And in fact, there's even mobile phlebotomy, so it makes it very, very simple. So you can do it either through drbredesen.com, or you can do it through apollohealthco.com, and you can get the testing, get initial. So we have a report. It's very much like a Cambridge Heart sort of report that you're getting for cardiovascular disease. This is typically about 55 to 65 pages of looking at, okay, here are all the things that represent your risk. Here are the things you can do about it so that you can really reduce your risk for cognitive decline.
Oh, that's great.
Before one more thing quickly I would add. There are frequently people who say, I'm here for prevention. And because this problem really sneaks up on you, as you know, and I'll give you an example. One woman who came several years ago, she said, this is in my family. It turned out she had a single copy of ApoE4, which increases risk for cognitive decline. And there are unfortunately 75 million Americans who have a single copy, about 7 million Americans who have 2 copies. And when she through her cognitive testing, her MoCA score was only 23. So she was already well into mild cognitive impairment. And by the way, she's done beautifully. Her MoCA score is now perfect 30. And she's doing, she's continued to do well. So again, getting in, she was there for prevention, but she was really there for early reversal. So just as you said, there are similarities there. And there's this kind of middle ground where people don't quite realize how bad things have gotten until they get tested.
Yeah. Back to your book. I love reading your book. There's one other chapter that I wanted to ask you about too. I think it's towards the end. It's with Abraham Flexner and his report on medical schools in 1910, and he revolutionized medical schools with his report. And can you talk a little bit about that? Yeah.
Well, it's a great point because, I call this Flexner's Reich, because he basically told all the rest of us unfortunately he's over 100 years ago. And it was a great thing at the time. He did a service. But as you probably know, he was funded by Rockefeller, who was trying to sell drugs. So he came to the conclusion, what a surprise, that we should close the medical schools that aren't focused on drugs. And so this really, unfortunately, drove medical schools from that day forward. As you know, about half the medical schools closed. Anyone interested in other forms of therapy got closed down. And I think on the positive side, what he said was medicine should be much more based on biochemistry and basic science, And I applaud him for that. And I think that this is why we all want to do the clinical trials and do the basic research and all that sort of thing. But imagine that someone had said 100 years ago, everyone who's going to fly in a plane, it must be in a biplane. Well, at some point you'd say, well, wait, we want to fly jets now. And unfortunately, medicine has really become out of date, in part because that report hasn't been updated. I would love to see a new Flexner report that says, what are the things that should be done for best outcomes? Because as we talked about earlier, we as physicians have done really well with simple diseases like pneumococcal pneumonia and tuberculosis and even HIV. But we have not done well with complex chronic illnesses like Alzheimer's and ALS and things like that. And so it's really a new day, and we need to reassess. If you think about it, Silicon Valley is all about disruption. How do we do the next thing, the next thing, the next thing? And the advances in Silicon Valley have been spectacular. Medicine is more about tradition and permission than it is about disruption. We ask, is it okay if we do this? Can we get reimbursed for it? And they say, well, you know, we're not quite there yet. So it's really an archaic system. And we need to look, again, more at best outcomes. So I look forward at some point to a new Flexner report.
It's almost as if the Flexner report was conceived in the intellectual climate of Louis Pasteur, with treating single illnesses with a with a single agent, and it makes me think that what made things so successful for the treatment of acute diseases and like rabies and anthrax at the time also eventually laid the groundwork for what has become the failure to treat chronic disease that we're facing today. And
absolutely,
maybe a little more Antoine Béchamp and less Louis Pasteur. The Antoine Béchamp was the soil versus seed, and Louis Pasteur was the seed versus soil. Hopefully, maybe a blend of those. But we're seeing the pendulum swing back, and I
think in the long run, it's going to be both. We're going to have targeted drug, pharmaceuticals on the backbone of overall personalized precision medicine protocols. I think that's where things are headed.
Yeah, it's an exciting time in medicine. I have to say that, I've never been more excited about the things that are happening in the last 10 years in medicine than the last, 40 years I was around. It was like, it's a great time, it's so exciting.
Yeah, and as a neurologist, we just watched people die all these years. ALS and Alzheimer's. And I think we're now at the point, seeing people get better from cognitive decline has been the most exciting thing I've seen. And just even getting the various emails. And that's why I wanted to get this book, The First Survivors of Alzheimer. So I had 7 people who had all gotten better tell their personal stories. I mean, they're really heartwarming to hear, oh my gosh, I was worried about my family. One of the people who wrote her story, a brilliant attorney from Harvard, who watched her grandmother die of Alzheimer's, watched her father, who was a brilliant neurologist, die of Alzheimer's,
wow.
And then realized that she also, the 3 of them all had the same risk factor gene. She then found out she had it, and she looked at her children and thought, oh my gosh, what's going to happen to future generations? She's done beautifully, and it's so great to hear this and hear her stories of how she got better and how well she's doing now. So yes, this is a great time, and it's the beginning. There's so much more for all of us to do to reduce the global burden of these complex chronic illnesses.
Yeah, and get the word out. We just interviewed Matthew Phillips, you may know, as a neurologist in New Zealand, who did a randomized controlled trial with ketogenic diet and Alzheimer's and got great results. But before that, he did it with Parkinson's disease, and it was a crossover, partially blinded trial, and even got some results there for neurodegeneration. So it's amazing time. Well, Dale, before we run out of time, as an expert in this area, you've spent your career in science investigating the very basics of this, and now your understanding of these lifestyle choices and the decisions we can all make. I have to ask, what lifestyle choices do you make yourself, if you wouldn't mind sharing, that you do in your own personal life?
Yeah, for sure. And I have to say, my wife, who's a family practitioner and who actually told me 25 years ago, whatever you guys find in the lab is going to have something to do with basic things like nutrition and exercise, sleep, stress, things like that. And I laughed and said, no, we're going to find one molecule with one fold. And of course, I should have listened to her 25 years ago. And our two daughters, they do much better than I do. They've been fantastic. But I try to absolutely and realize that these are important. And the one thing is wearables. We haven't talked about wearables. They are changing the world. You can now find out what your oxygenation is at night. You can find out what your heart rate variability is. You can make sure you've got enough exercise in. You can look at your VO2 max. You can look at your telomeres. You can look at your genetics. You can look at your microbiome, your continuous glucose monitoring, which we find one of the most helpful. So this has been fantastic. And I check my own rate ability and I check my oxygenation to make sure I don't have any problems with that. So what I try to do is the basics. So for diet, I try to eat a plant-rich, it's not purely plant, I try to eat a plant-rich called KetoFlex 12-3. It is a plant-rich diet. I do a time-restricted eating for 8 hours during the day. And then go 16 hours of fasting. Now, I don't recommend that for people who are really, really thin and don't have any body fat. I'm an old man. I've got some body fat to burn, so I can make some ketones. I often check my ketones with a breathalyzer, very simple, something called BioSense. See what I'm blowing for the ketones to make sure that I'm making some ketones, and that they're not too high, that they're not too low. Then make sure to get an exercise. Typically do 10,000 steps. I usually do a little bit of weight training, in fact, I've just gotten some Katsu bands, these restrictive bands, which actually are turning out, I was very skeptical about these. Some of the Olympic athletes use these, by the way. They actually basically slow down the flow to muscles just a bit. And so when you're finished training, first of all, it takes less training, and then you get better flow overall, which is a huge issue for many people. And so exercise, and then make sure that I'm getting 8 hours of sleep a night. And of course, you and I, when we're interns, we get virtually no sleep, and I'm sure that has some damaging effects on my nervous system. But I've tried to then continue to get good sleep. And then try to keep stress to a minimum. You should, it's fine to have some stress, but you don't want to have chronic stress. That's the thing that kills you. And then I check my blood pressure, and I can see very clearly, when things are bad, it's up. When I'm doing the right things, it's coming down. And then I do some basic detox. So I get into the sauna, typically, and I probably don't do that enough, more like once or twice a week. As you know, the Finnish study showed that men who were doing sauna 5 and 6 times a week lowered their Alzheimer's risk dramatically. I mean, it was striking. So do some basic detox, filtered water. And then I'm very big on fiber because it turns out, the prebiotics and probiotics, getting your gut healed and then getting appropriate microbiome. And then I do the same thing, oral microbiome. There are now oral probiotics and prebiotics, or probiotics for the oral microbiome. And there's, again, you can check this with oral DNA, simple way to look to see. As you probably know, there was just a trial on looking at the P. gingivalis in the brain and basically trying to prevent one of its proteases called gingipane. And it's interesting, the trial failed overall, but it actually looks promising in that group that had the P. gingivalis in their mouths and not in the ones that didn't have P. gingivalis, which makes sense. So those are the basic things that I do. And then, of course, as far as brain training, just basically trying to keep up with the latest literature and things like that. And so, yeah, just like everyone else, I'm interested in avoiding a cognitive decline. I always ask people, how many people here would like to avoid Alzheimer's? And most people will raise their hands. I think most of us would like to avoid Alzheimer's.
Well, thank you so much, Dale, for sharing your knowledge with us and spending an hour of your time. And I just want to thank you also for the great work you're doing to revolutionize the treatment of this disease.
Thanks so much, Rob, and really love working with you. Look forward to continued work. I think, imaging is a critical part of this. And as you're indicating here, health longevity secrets, it's amazing how much can be done today that we didn't know, even a decade or two ago.
Note, this is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have. Never disregard professional medical advice or delay in seeking of it because of something you have seen here. If you find this to be of value of you, please hit that like button and subscribe to support the work we do on this channel. Also, we take your suggestions and advice very seriously. Please let us know what you'd like to see on this channel. Thanks for watching, and we'll hope to see you next time.